that there is increase in the tubular fluid inulin and plasma inulin ratio. Initially it is 1, but it increases. It is more than 2.33 or so. But the osmolarity remains same. Milliosmol per kg at the beginning, and it is the same value, But inulin ratio, it is more than 2.33. So it proves that roughly 2/3 of this water that is present initially is reabsorbed, and osmolarity remains the same, and it at the same time proves that the 2/3 of the filtered load besides water, there it is reabsorbed. It is followed by the water, and in this way 65% of the filtered load is reabsorbed. And in this case, there is the role of aquaporins. Aquaporins. 1, 2, 3. There are other also aquaporins. Aquaporins, that it causes facilitated diffusion of water. You can remember their structure, because many days has passed away, and it is expected that you are reading thoroughly. Our classes are not satisfactory, not up to the standard, but there are good number of standard textbooks are available, and you are also standard students. So it is expected that you know, in some cases better than me in this early stage. Clear? Aquaporins, you know, water can imbibe through the cell, in between the cells. In spite of that, when rapid water transport is required, there is the need of facilitated diffusion, and it is due to aquaporins. Aquaporin 1, 2, 3. There are other aquaporins, not only human beings, rat, mice and other mammals, aquaporin has been detected. Lacrimal glands and aquaporin 5. There are also other aquaporins. You will learn in the text, and their structure is like 4 subunits, and also there is another 4 aquaporins. 4 subunits, and each subunit where this water pass through them, and there is also a spore at the central point also. Current textbook means this type. There is a aquaporin structure. Like potassium channels, they are 4 subunit structures. So these are in the general physiology, transport across the membrane, and in this way 65% of the filtered load is reabsorbed passively. Now water is coming through the descending limb of loop of Henle. In cortical nephrons, there is very small, thin ascending limb, thick ascending limb. Water is reabsorbed from the thin descending limb of loop of Henle. Whether it is cortical nephron or it is juxtamedullary nephron, part of the Henle loop is in the medulla. It may be outer medulla or inner medulla, whatever it may be. Outer medulla, in this case, if you consider the cortical nephrons, then this thin ascending limb of loop of Henle is short or non-existent. There is the thick ascending limb of loop of Henle, thick ascending, and this part water is impermeable, and this part is water impermeable, and everywhere there is the permeability. Yeah. And in the loop of Henle, 10% of the filtered load is reabsorbed. So locally 10%. So 75% is reabsorbed. Here. And distal tubule, if you consider it is the distal tubule, it is in effect and extended, is not high. Distal convolutive, and here 5% of water is reabsorbed. 5%. Distal convolutive, 5% is reabsorbed. It is relatively less permeable to water, and because of its length, 5% of the filtered water is reabsorbed. Then it enters into the collecting tubule or collecting duct. And in this way, it is eliminated. Ultimately enters into the renal pelvis. Whether it is cortical nephron, juxtamental collecting tubule is responsible for rest of this. So in this way, you will find that up to the beginning so in that case, up to this level, 80% of this, so tubular fluid, inulin, now this fluid is passing through, and normally in the cortical collecting tubule, 10%, is reabsorbed. Cortical collecting tubule. And medullary collecting tubule, whenever the concentrated urine is formed, 4.7% or so, and remaining is eliminated in the urine. Medullary collecting duct. Whenever there is concentrated urine is formed, and in case of concentration, we have to consider the osmolality and not the specific gravity, because the osmolality depends upon the number of the particles and not its nature. Specific gravity of urine is a rough guide of concentration, but in the text, whenever this type of discussion is done, they all consider the osmolality. Osmolality of the plasma is normally it is 300 to 85. And concentration of urine is, when it is concentrated urine, it is 1200, extremely 1400 milliosmol per kg. And when it is dilute, it may up to 30 milliosmol per kg, when it is extremely dilute. And the volume of urine depends upon the osmotically active particle it has to deal with. You can take in an adult individual 700 milliosmol to be eliminated. It includes the redundant electrolytes and also metabolic wastes like urea, uric acid, creatinine, etc. And in this way, it depends upon the diet also and metabolism. You can consider this as 600. If you take this value 700 to be eliminated, and whenever there is maximum concentration, urine is eliminated. When there is scarcity of water and there is extreme dehydration, and when this amount that is eliminated remains constant, if this falls short of that value, then there is accumulation of toxic products. To remain healthy, we have to eliminate this within a day, and whenever there is extreme concentration, to eliminate this, we must to produce urine 0.5 liter per day. Which we produce. Or when urine is extremely dilute, 30, then 23.3 is the liter per day is eliminated. बुझे गल? You divide this with this, you get this value. Milliosom per kg, or what in case of water it is expressed in liter, it can be expressed. So if you divide this value, you get this value when the urine is extremely dilute. So in physiological conditions, you can think that in spite of complete dilution of the urine, maximum capacity beyond which dilution is not possible, 87% of the filtrate load is reabsorbed. এটা বোধগম্য হলো? Whenever, these are all extremely easy things. Whenever there is no action of antidiuretic hormone or vasopressin, the individual is drinking plenty of water, and in that case it is 23.3 liter per day in health, but this 180 liter you have to per day everywhere. So it is 87% or so. 87%. So 0.5. So the range is from this point up to this point. Within range, there is excretion of the urine. Clear? Because we have a limit to concentrate our urine, and we have to limit to dilute the urine, and within it you can vary. এই ডিস্টেন্সের মধ্যে তোমার so when this is this value 1400, and in that case tubular fluid inulin plasma inulin ratio is 300 or so. Tubular fluid inulin and plasma inulin ratio is 300 or so. 300. Whenever this condition is produced, it is highly concentrated. Inulin is chosen in that inulin is not touched by the tubules. It is neither reabsorbed not secreted. Clear? So it's constant. When this is the concentration, you can easily calculate what should be the urine remaining in this position. In this position, 300. Yeah. Tubular fluid urine divided by plasma urine. When it is 300, and if the GFR is equal to 180 liter, you can calculate what is the urine that is formed. Calculate. Tubular fluid urine. The filtered load remains constant. There may be change in the GFR, but there may be, and this GFR multiplied by this value, plasma value, filtered load remains constant in this position, because we are considering that is the GFR is remaining constant, but it can be concentrated or diluted, and whenever the maximum concentration, this ratio is 300, and tubular fluid concentration is equivalent to that of the urine concentration. So the same mass is present. Conservation of mass. Clear? Conservation of mass. Concentration remains same. Concentration differ, but the total mass remaining is constant. At the very beginning, it is 180 liter, 180 urine, and it will be equal or tubular multiplied, and when it is urine, it is the so this ratio, so this is equal to 180, and if it is 300, you divide it by 300, 180 by 300. The type of value you can get. So by the micropuncture technique, it has been possible to know what amount of water remaining in that part and what amount is reabsorbed. And it is given in formula form in your text, good text. When we go through the text with some attention, it will appear it is an easy thing. Clear? We have mentioned that in proximal convoluted tubule, normally 65% is reabsorbed. Roughly 2/3 of the filtered load, besides water, is reabsorbed, and it is followed by equivalent amount of water. So the osmolarity remains constant at the very beginning and at the end of the proximal convoluted tubule, but there is increase in the ratio, and whenever it is at the end of the distal convoluted tubule, 80% is reabsorbed, 65 plus 10 plus 5, and in that condition this ratio will be 5. In the cortical collecting duct, it is 10% is reabsorbed, and the medullary collecting duct, outer medullary, inner medullary, and then the papillary collecting duct, small part, and in that way 4.7% is reabsorbed. So only 0.3% remains whenever there is formation of concentrated urine. So 180 multiplied by 0.3 by 100, you get a value of 0.54 liter per day is produced. But on the other hand, whenever there is dilute urine is produced, individual is taking plenty of water, and then it is eliminated in higher volume. maximum dilutional capacity of human individual is 30, given in reliable text, 30 milliosmol per kg or per liter of water. And in that condition, 23.3 liter per day is produced. Whenever this osmotic load is 700 milliosmol per day, and it will depend upon the diet, sodium intake and metabolism also. Whenever there is more excretable substances, and then urine flow must go on increase. But our capacity is within this value and this value. Within this value we can change. Clear? And how it is possible? Because in this medullary part, there is gradient of osmolarity, and it is given in the examination, the university examination, in this supplementary examination. And I am happy to read these answers, and they give very good answers. Most of them has no even grammatical mistake and clear conception. So I was at liberty to give them marks. Easier, it is not difficult for you to learn. And there is osmotic gradient that go on increasing, osmotic gradient. And in the case of cortical nephrons, that is 600. And when at the level of the papillary collecting duct, it is 120 milliosome per kg. In the interstitial fluid, and it is produced. Clear? That is, the osmotic gradient is produced in the interstitial fluid of the cortex. It is equivalent to that of the plasma, and it is 300 milliosmol per kg, and there is high vascularity. So there is no accumulation in that case. But when you go deeper and deeper into the thickness of the medulla, at the junction between the outer medulla and inner medulla, it is 600 milliosmol. And whenever this concentrated urine is produced, it is 1200 milliosmol at the level of the papillary collecting duct. Inner medullary and terminal part called papillary collecting duct. It is 1200 milliosmol per kg. And this is the interstitium, within interstitium it is. And its vascularity is relatively less. Reticular capillaries flow in the cortical part is high, and as you go to the deepening, and in that case the vascular flow is also, flow rate is also reduced, and there are mechanisms by which there is substantial accumulation of osmotically active particles. It is sodium chloride and urea, so that its concentration is going on. It is more and more at this, and maximum value is 1200 to 1400, and it is the region by which it is possible. And this water that is reabsorbed in the proximal tubule, 65%, it is obligatory. It is the obligatory. Whether you intake less amount of water or more amount of water, this part of the filtrate is reabsorbed, because the electrolytes, sodium chloride, these are reabsorbed, and they are followed by corresponding amount of water to maintain the isotonicity. Yeah. But the remaining part, that is the distal nephron, collecting tubule, mainly collecting duct, and here it is called facultative. Facultative. মানে লোক যখন প্রচুর পরিমাণে জল খায় বা যারা অ্যালকোহলও খায়, একটু অ্যালকোহলও খায়, তাদের এডিএস সিক্রেশন কমে যায়, their urine flow rate increases. It is a device of the nature. On the other hand, when the individual is deprived of water in the hot conditions during summer days, then the urine volume go on decreasing, concentration increasing, maximum value is 1400 liter. Now you are interested to know how it is possible that here there is this type of gradient is produced. 300 millismol per kg in the cortex to 600 at the junction of the outer and inner medulla in case of cortical nephrons. So it is produced by the counter current exchange mechanism. There are two terms, counter current multiplication and counter current exchange mechanism. Loop of Henle is counter current multiplier. Counter current multiplier, and this vasa recta are the counter current exchanger. And this examination script that I have checked, their answer is very good, and it is easy to learn. In spite of that, I have to explain in brief. You consider the case of cortical nephron, loop of Henle. And it is the medullary interstitium. It is the thick ascending limb of loop of Henle. And the behavior of their absorption pattern is different. The thin descending limb of loop of Henle is highly permeable to water. It is highly permeable to water, but it is less permeable to electrolytes. Thin ascending limb of loop of Henle, that is almost, it is short in case of cortical nephron. It is relatively impermeable to water, but permeable passively to sodium chloride and urea. And urea. So the thick ascending limb of loop of Henle, it is permeable to sodium chloride by active transport. Active transport. Sodium potassium 2 chloride ion transporter, active transport. Secondary active transport in this. And by flow stop mechanism. Flow stop. During flow there is less diffusion, but in the stop phase there is the change in the osmolality due to this active transport by the cells of the thick ascending limb of loop of Henle. So you consider this initially very beginning. These are going away, and now this is this position. There is flow. During flow, there is this change at this level, not at this level, and 200 milliosmol containing hypotonic fluid has gone out of this thick ascending limb of loop of Henle. Now if you stop it and allow it to continue. Now then it will be fine. You will find this condition. Yeah. And then again flow. Then fluid will come out. These two levels will come out, and the same process will be repeated. And in this way, hypotonic fluid will go out through this, and isotonic fluid is coming intermittently, and in this exchange occurs, and this development of this medullary gradient in this way. In this way. In your text, you will find at different level, more levels, and when you read this, then it becomes extremely easy. In older texts, they gave the example of heat exchange, and countercurrent means that is the inflow is opposite to and counter to the other, and they are close together. If you take a straight tube and you bend in you so that the limbs are in close position, so that then exchange across them is possible. And older text, they shown this as the heat transfer from the one limb to another limb. Suppose in that case, they shown in this way, and there is a heating device, and it is going out through this way, and they are in connection, and it is a metallic element. It can transfer heat from this side to right side to left side. And if you give heat so that flow is 10 ml per minute, and heat is given 100, and when it becomes 100, and the water that is coming, and after some time it will in this way. So it is 0, it is 10 in this way. Heat is exchanged. Yeah. This outgoing water is giving heat to the incoming water, so that this is changing in this way, and the heater is. So idea is that there is counter current exchange of heat, and at a particular level it is called this multiplied. If it is straight, then across this tube is there, but in this case it is depending upon its height, then effect will increase, and from this level to this level is produced, this effect. But if it is a straight tube, and so you have to give the heat to all the part, energy utilized is the same, but it helps in this distribution in suitable manner, and it is called counter current exchange or counter current multiplier in this sense. In a particular level that is occurring, it is called single effect, and the total effect along this length, and then it is multiplied many times. Suppose you have a capillary, a renal tubule, if you say, it is few mu m in length, and here you can give the gradient, but it is spread over more than centimeter, more than 1 centimeter or so in the UTU. If you give the cortex in the medulla more than 1 centimeter in an adult kidney, it is spread. So, it is multiplied in this sense. Or in some text, it is said that urine is coming on and going out. So, it is multiplied in that sense. Older text explain this with heat. That is, the heat from this right limb is being transferred to this limb. And it is particular horizontal level, it is called single effect. It is called counteraction and multiplier mechanism. And it is an active process by the thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle. If you consider this loop and it is the intestine in that case, what occurs? And in that is the one sodium ion is moving. Sodium gradient that is maintained at the basolateral membrane, that is the sodium potassium ATPase going out and potassium is going on. Potassium. 3:2 ratio, you know that. Now this potassium is coming out and this chloride ion that enters, it goes through the chloride channel, and whenever there is Bartter syndrome, B-E-R-T-T-E-R, Bartter syndrome, there is different reason. Primary reason, if this channel cannot function properly, so there is loss of sodium, potassium and chloride in that case. And sodium loss means loss of interstitial fluid volume and renin angiotensin is activated, but there will be no hypertension, there will be no alkalosis or potassium level within the normal limits, or it may be due to this channel, defects in this channel or defect in this chloride transport. And within the ER, there are chloride channels are present. They are Ka channel, Kb channel. Whenever this Ka channel is active, then there is no hearing loss. But if there is defect in the Bartin or defect in the Bartin, and then there is hearing loss, because it is required for Kb channel or E channel also, Ka channel also. The Bartter syndrome, it is called. Now coming to this remaining part, that is the and multiplication is due to the continued active transport of sodium chloride from the thick ascending limb of loop of Henle. Clear? Thick ascending limb of loop of Henle, and rapid outflow of water from the thin descending limb of loop of Henle, and also urea transport in the thin descending limb and thin ascending limb. The role of urea is a substantial. Even in some cases, whenever there is 1,200,1400 milliosmol, then 50% of the electrolyte in this case of urea. Urea enters through this. Urea enter through this thin descending limb, but it remains almost non-absorbed in the remaining part. That is the distal convolutional, cortical collecting duct, outer medullary collecting duct, inner medullary collecting duct, but in the papillary collecting duct, terminal part, it is again permeable, highly permeable, and to some extent depends upon with ADH. So whenever there is the need of conservation of more water, urea will come, So in this, its role is also there. Role is 50% due to sodium chloride and 50% due to urea. When there is concentrated urine is produced. এরা হাসতে ভাবছে যে কিসব সহজ ক্লাসগুলো এরা কি করছে, কিন্তু কিছু করার নেই। পরবর্তী বছর হয়তো উঠে যাবে এইসব সাবজেক্ট, যে বই পড়ে শিখে নেবে, এভরিথিং ইজ রিটেন দিন বুক। যেমন আরজিকর মেডিকেল কলেজে এখন হয়েছে কি, যে বলছে যে তোমরা ক্লাস করো কেন, তোমরা ইন্টারনেটে সব দেখে নেবে। ওদের ওখানে এরকমভাবে উৎসাহ দিয়েছে অথরিটি, যার ফলে আমরা যেসব জায়গায় লেকচার ক্লাস নিতাম সেগুলো ওরা সফটওয়্যার কোম্পানিকে দিয়ে দিয়েছে আর ছেলেদের বলে দিয়েছে যে তোমরা এত ক্লাস টাস করতে হবে না, তোমরা সব ইন্টারনেটে দেখে নেবে। এই জন্য 50% ছেলে ওখানে ক্লাস করে রেগুলারলি, যা শুনেছি, আর 250 ছেলে সেখানে, আর বাদ বাকি সবই থেকে পড়ে নেয়, মানে ইন্টারনেট থেকে পড়ে নেয়। বুদ্ধিমান ছেলে তোমাদের মতো এই জন্য ক্লাসটা, কিন্তু আমরা এখানে এটা আমাদের এখানে হবে না, বুঝতে পেরেছো? কালক্রমে হবে, হয়তো আমরা চলে যাওয়ার পরে হয়তো আর অ্যাডভান্সমেন্ট হবে, কিন্তু আমরা পিছনে ধরে রেখেছি সেই যে আমাদের এখানে ক্লাসের জন্য আমরা ছেলেদের বলছি। তাতেও এরা হাসছে কেন, যে এরা সব অবান্তর কথা বলছে। সেই কি করা যাবে বলো? হ্যাঁ, কাউন্টার কারেন্ট এক্সচেঞ্জার and it is called counter current multiplier by the short note counter current multiplier. Then you should discuss more with these renal tubules, loop of Henle. Thin ascending limb is absent in there. Thin as a bar, if in cortical, in juxtamedullary nephron, there is a thin descending limb, and in that case there is sodium chloride and urea is coming on. Sodium chloride and urea is coming out by passive diffusion, because it is high concentration within and it is passive diffusion. So it is the longer the loop of Henle, more is the concentration gradient that is produced. And nature knows what is the absolute requirement, that is this outer medullary or cortical, that is this thick ascending limb, their function is sufficient in that case. The remaining part, the thin ascending limb of the juxtamedullary nephrons, they are relatively impermeable to water but permeable to sodium chloride and urea by passive diffusion. And in the papillary part, whenever that concentration is produced with the help of the ADH, the permeability, normally it is permeable to urea, permeability even more increased. So it is coming, and in this way they have a role. And counter can exchange by the vasa recta. In case of vasa recta, it is a passive process. With a particular level, at a particular level, it is and as there is continuous flow, so that there is a 25 due to this flow. So whenever this is occurs, the water has a tendency এটা এক তুলনায় লঘু, so water will try to move from this, that is the descending vasa recta to ascending vasa recta. It is fenestrated, it is more permeable, and urea it will come from this side. So that there is a recirculation of sodium chloride and urea, and water try to bypass it, and the outgoing fluid is to some extent more osmotically active particle, because it will drain the electrolytes and the water that is being reabsorbed by the collecting tubular collecting duct. Some amount of urea and sodium chloride is taken back, because there is a limit to which it is produced. And it is called counter-counting exchanger, and it is a passive process. Both the ascending and descending limb of vasa recta, vasa recta is coming from the peritubular capillaries of the juxtamedullary nephrons. They provide the peritubular capillaries. Besides this, they have long hairpin loops up to the tip of the renal papilla. Clear? And as there is flow, there is not absolutely equilibrium at any level. Suppose you take this level, at the very beginning it is 300 and the out level for reference, and here it is 400, it is 425 and 450. So water will try to percolate or diffuse from the lumen to the interstitium and to the ascending limb vasa recta, and sodium chloride and urea as 450 is more than 2 and so there is diffusion of this and in this, and the diffusion capacity is more in the, as there is this limb is fenestrated, there is, so some of the electrolytes and urea they are reabsorbed along with the water, so the flow through this is to some extent more than this of this, whatever it may be. And in this way, in this, suppose it is 300 and the cortex, mechanism is not applicable only in this case. Body utilizes it in other ways, in aquatic animals or even in the human beings. When you dissect in the anatomy, you must have seen that the artery and veins, they are close together. It is nature's device so that they remain close together. When an individual is exposed to cold water, suppose there is some shipwreck, the individual is exposed in the cold water, then the blood going to the periphery through the arteries, they are warmer coming from the heart and they will transfer heat to the neighboring veins coming from the periphery, from the feet. So idea is the nature is the counter current exchange in this mechanism, the heat. That is, this foot may be cold, but relatively warm water will go into the heart, so that the heart muscles and the brain will get relatively more heated part. It is a nature's device. And this type of counter flow is in some parts of the GI tract, mucous membrane also you can find. Clear? So these are the mechanisms by means of which and which factors responsible for increasing this medullary gradient. One is the, if GFR is low, less fluid is available to the loop of Henle, and there is every chance of more concentration within the limb and over the interstitium. Less blood flow is favored. Normally there is much less blood flow at the level of the cortex and at the level of the medulla. Less blood flow. Cortical blood flow per gram of tissue is 5 ml and 0.6 ml in the inner medulla also, blood flow. So whenever there is fall of GFR, then there is more gradient that is produced. And blood flow is low, and there are some prostaglandins or that is the body metabolites that has some control. They can regulate it to some extent. So these are the factors, and the number of the juxtamedullary nephrons in different species. In human beings it is 15%, in others it is more, and also thickness of this renal medulla. It is more in case of rats and desert rodents, and in case of dogs, in human beings is 1400, and in the dogs it may be 2500. In rats it is more, and desert rodents it may be 5000 milliosmol concentrating capacity. I think it is all for today. Time is up. So we will discuss osmotic diuresis also in the next class. And you have your examination, second internal assessment. Which date do you know? তোমরা ভালো করে একটু পড়ে নাও, সহজ জিনিস এগুলো।
So good morning everybody. So you have reached the last phase of your final examination. It is the last phase, the last item, last part, that the head, neck and brain. So we start with the neck. There might be slight difficulty as you have not yet to complete the abdomen. The dissection of the head neck will start in the next week. Just to have an idea, and it is also good so that you have got a preliminary idea about the head neck. First we start with the neck, and you know, in the anatomy, like in geographical area, if we look from drone or from aeroplane, these area look like a single land with houses, rivers, etc. But for sake of clarification and for reference, we divide this area number of parts. This is Birbhum, and within the Birbhum there are certain areas, Muluk, etc. It is Bardhaman, it is divided into parts. There are river, there are roads. Similarly, anatomy is nothing but to know the area, to know the geography of the of our body. So, when we find a head and neck, suppose there is a tumor in the neck. It is of no meaning. There is a tumor in the neck. Why? Here. Tumor in the head. So it is of no meaning unless we classify certain areas so that we can pinpoint. So we divide the neck region into triangles. So first of all, you know what is the neck. Neck is starting from here. It is known as the symphysis pubis here. Then the medulla in the same line is this bone is known as the mandible. And the middle of the mandible we call, like symphysis pubis, we call symphysis menti. It is called symphysis menti. This area is known as the mentum. So it is known as the symphysis menti. And this bone is the mandible. So this is the symphysis menti. And this is the lower border of the mandible. This is the lower border of the mandible. This bone is known as the mandible, right? And then the bony prominence is here. It is known as the mastoid process of temporal bone. Mastoid process of temporal bone. Then we proceed. This is the occipital bone, and there are lines. There is another prominence here. We call the external occipital protuberance. And from the mastoid process and external protuberance, I will see you in the PPT, there are two lines, rather three lines. We call them highest, superior and inferior nuchal line, whatever it may be. So, if we in living condition, this is the symphysis menti. This is the lower border of the mandible. Just behind the ear, you feel it, this is the mastoid process. And this is the external occipital protuberance, and this is the superior nuchal line. These lines and external occipital protuberance is present in the occipital bone. So the neck boundary, in the upper boundary is that symphysis menti, lower border of the mandible, then an imaginary line, because there is a gap. There is no bones here. So we draw an imaginary line from the, and this region, this is known as the body of the mandible, and this is known as the ramus of the mandible. This is known as the body of the mandible, this is known as the ramus of the mandible. And at the angle between the body and the ramus, we call angle of the mandible. So, from the angle of the mandible to the mastoid process, we draw a line. Imaginary line. Kono line nei, amra draw korchi. Then mastoid process, then the superior nuchal line, and this is the occipital protuberance. This is the upper boundary of the neck. And while in the mastoid process, you look, there is a projection. It is known as the styloid process of the temporal bone. All these are mastoid process, styloid process is a very important bone. This bone is known as the temporal bone. And this is the opening of the external acoustic meatus, bony opening. But if we look here, is it bony? No, it is cartilage. So here there attached a tubular cartilaginous part of the, এটাকে আমরা বলি, I call it external acoustic meatus. Meatus on a passage. External acoustic meatus. It has got a bony part. Bony part is here, and a cartilaginous part which is attached to the external ear. And this part, এই জায়গাটা দেখো, এই জায়গাটা পরে বেটার এই শুরু হয়ে যাবে, known as the tympanic plate. এটা ইম্পর্টেন্ট লাগবে, তার জন্যই বলে দিলাম। তাহলে close to the and just anterior to, there are two other bony prominence. One is the styloid process and tympanic plate of the temporal bone. তাহলে ওপরের বাউন্ডারিটা আবার নেকের বলি, symphysis minti, angle of the mandible, then an imaginary line from the angle of the mandible to the mastoid process touching the tympanic plate, then the superior nuchal line and external occipital protuberance. This is the upper boundary. And lower boundary, all of you know, it is the superior aperture of the thorax. In thorax, you know, the midpoint of the notch, suprasternal notch, then the upper border of the manubrium sterni, then the clavicle, then the outer border of the acromial process, then of the spine of the scapula, and the C7 spine of the cervical 7 vertebra. So this part is the neck. Clear হলে ওপর কন্তটা গেট উপরে, এটার উপরে হয়ে গেল ফেস আর এটার উপরে হয়ে গেল নেক। নেকের মধ্যে আরেকটা ঝামেলা হবে পরে যখন স্ক্যাল্প পড়াবেন, কিছু পার্ট স্ক্যাল্পে, বোথ নেক অ্যান্ড স্ক্যাল্পে ইনক্লুডেড, ছেড়ে দাও এখন ঝামেলায় যাবে। So it is the neck and you find skin here. If we cut the skin, what you find? Whenever in body, cut the skin, what do you get? Superficial fascia. But there are certain specialist area is there. Come on. Key specialty area? Just last class বলেছিলাম, if we cut the skin of the scrotum, what do you find? Normally, dartos, superficial fascia now changed into a muscle known as the dartos muscle. Both superficial fascia and fascia of scarpa or become intermingled and to contain muscle fibers in the scrotum. It is known as the dartos muscle, smooth muscle supplied by the sympathetic nerve. বারবার বলি কেন যাতে মনে থাকে। Come on, গেল। Similarly, in the neck, greater, not in the posterior, greater part of the neck, anteriorly and laterally, if we cut the skin, you find the superficial fascia, and the superficial fascia, you find a muscle known as the platysma. Platysma is well developed in animals, quadruped animals. All over the body it is present, so that when it contracts, wrinkling of the skin of the cows and horses you can see. But in human, it is ill developed and function is very minimum. This platysma attached here lower border, symphysis menti, lower border of the mandible up to angle. Then it goes downward, ultimately passes over the clavicle and joins with the fascia covering the pectoralis major muscle. This is the platysma muscle. When it contracts, it causing hollowing of the side of the skin. Then you cut the platysma and move it, sir, you find a deep fascia. In face, there is a no deep fascia, but in neck, deep fascia is present. And peculiarly, kothao nei, these deep fascia are arranged as a 3 tubes covering the neck. প্রথমটা এরকম covering all the structures of the neck, we call investing layer of the deep fascia. Attached back is attached to the spine anteriorly attached to the upper border of the mandible, symphysis menti and so on and so on. এরকম ভাবে কভার করছে। And lower clavicle scapula তে লেগেছে পেছনে। So investing layer of the deep fascia, it invests all the structures. So we call the investing layer of the deep fascia. And from this deep fascia, extension goes deeper and there is another tube, another layer covering the trachea. We call pretracheal layer of the deep fascia. Similarly, another more deeper layer is present which covers the vertebra. We call আসবো আমি এখন কিচ্ছু লিখবে না, আজকে লেখার কিচ্ছু নেই, জাস্ট আইডিয়া করার ক্লাস। থিওরিটিক্যাল ক্লাস শুরু হবে কালকে, আজকে জাস্ট আইডিয়া। তাকে আমরা কি বলবো? প্রি ভার্টিব্রাল লেয়ার অফ দ্য ডিপ ফাসা। মানে টিউব, within a tube there is another tube and within that tube there is another tube. This is the disposition of the deep fascia and there is a certain specialization of the deep fascia also. It is important and I will come later on. So with this, then we cut the deep fascia, then we find the muscles present, of which the most two important trapezius. Trapezius, you have got idea in the supex when you read the scapula. Next, some idea about the bony, otherwise you cannot proceed. So, I have described this. It is the lateral view, symphysis menti, angle of the lower border of the mandible. Lower border of the mandible, another name is the base of the mandible. Base of the mandible is equal to lower border of the mandible. Finished. This is the mastoid process. This is the styloid process. This is the tympanic plate, external acoustic meatus. Then it is the superior nuchal line. This is the cervical vertebrae. There are 7 cervical vertebrae, C1, C2, C3, C4, C5, C6 and C7. Then the first thoracic vertebrae. So it is the backside bony structure. It is the vertebra. This is the spine of the vertebra. These are the transverse process of the vertebra. Anteriorly, just below the mandible, there is another bone is present. We call it hyoid bone. এই জায়গাটায় ফিল করো, এখানে পালবে না, একদম ভেতরের ডিপে হাইওয়েড বোন। যখন থ্রটলিং করে, ইট ইজ এ ভেরি ইম্পর্টেন্ট ল্যান্ডমার্ক ইন ফরেন্সিক মেডিসিন। কাউকে মেরে যদি ঝুলিয়ে দেয়, অ্যাজ ইফ ইট ইজ এ সুইসাইডাল কেস, ইউজুয়ালি যখন থ্রটলিং করে হাইওয়েড বোন ফ্র্যাকচার হয়ে যায়, যেটা নর্মাল সুইসাইডাল হ্যাঙ্গিংয়ে হয় না। সো ইট ইজ দ্য ওয়ে one can say that it is a suicidal hanging or a not. Must be corroborated by other factors also. Throttling করলে যে হাইড বোন ফ্র্যাকচার হবে তার কোনো মানে নেই। It is one of the point. Hyoid bone has got a body and two horns, superior, greater cornu, horn এখানে cornu বলা হয়, greater cornu and a lesser cornu. ছেড়ে দাও, পরে আসবে। It is a cartilage known as the thyroid cartilage. And we start here the larynx. From the upper border of the thyroid cartilage starts the larynx. So, it is the thyroid cartilage. It has got an angle of the thyroid cartilage. The superior horn, this is the inferior horn. Below the thyroid cartilage, there is another cartilage known as the cricoid cartilage. And this is another cartilage. This is known as the epiglottis. দেখতে পাই। These are all cartilages of the larynx. In the lower border of the cartilage, cricoid cartilage, it is the larynx. এটা হচ্ছে larynx. Starts the trachea. Here starts the trachea. This is the first cartilaginous ring of trachea, second, third, fourth. And here lies an important viscera here, extending up to the lamina of the thyroid cartilage, known as the thyroid gland. Known as the thyroid gland. It is very important. Tale thyroid gland is located anteriorly to the thyroid cartilage, cricoid cartilage, and first, second, third, fourth ring of trachea. এই জায়গাটায় থাইরয়েড গ্ল্যান্ডটা রয়েছে, এই যে এই আইডিয়া হলো। নিচে all of you know, this is the menothelium sternum, this is the clavicle, this is the scapula. So you must have an idea to proceed next. So it is the cervical vertebra, atlas, second, third, fourth, fifth, sixth, and seventh. And the tips of this spinous process of the cervical vertebra, there is a strong triangular ligament is attached, very strong, and shape is triangular, and it is called the ligamentum nuchae. Nuchae means neck. So, starting from the base of the occiput, a strong ligament is attached, known as the ligamentum nuchae, very strong, এতটা চওড়া, এরম ভাবে। এই জায়গাটায় বাইফিট স্পাইন, এই স্পাইনের বাইফিট খাদে লিগামেন্টাম নিউকি থাকে, এরম ভাবে, ঠিক এরম ভাবে লিগামেন্টাম নিউকি থাকে। So actually anything directly spine cannot attach. It attaches through the ligamentum nuchae. And this is the bones, already you know. This is the mandible. Very important bone known as the zygomatic bone. And this is the zygomatic bone, and we call it the zygomatic arch. Very important. We call it zygomatic arch. এগুলি লাগবে আমার। Zygomatic arch. তারপরে এটা বুঝতেই পারছো, mastoid process। কেমন? This is the zygomatic bone. This is the zygomatic arch. This is the opening, external acoustic meatus, mastoid process. It is the styloid process. This is the ramus of the mandible. This is the body of the mandible. And this is the maxilla. And it is the posterior view of the skull. You find there is an এই জায়গাটা, it is known as the external occipital protuberance. আদৌ উঁচু যে জায়গাটা লাগছে ঠিক এখানে, it is the external occipital protuberance. From there, two important lines goes from, it is a midline to laterally. It is known as the superior nuchal line. It is known as the inferior nuchal line, and above it a faint line is present known as the highest nuchal line. So there are three nuchal lines: highest nuchal line, superior nuchal line, and inferior nuchal line. Come on. And here there is a raised border we call external occipital crest. Why external? Inside ওরকম আছে। ভালো করে দেখলে সুপিরিয়র ইনফিরিয়র, কেন একটাকে এক্সটার্নাল বলা হয়? ভেতরেও দেখো আরেকটা ক্রেস্ট আছে, তার জন্য এটাকে বলা হয় ইন্টারনাল অক্সিপিটাল ক্রেস্ট। এখন লাগবে না, এটা কার্টিলেজ, থাইরয়েড কার্টিলেজ, ক্রিকয়েড কার্টিলেজ, ট্র্যাকিয়াল রিং, দিস ইজ দ্য এপিগ্লটিস। এরপরে দুটো আরেকটা লাগবে আমার, তার জন্য আমি দেখিয়ে দিচ্ছি। There are two important salivary glands. One is the parotid gland overlying the angle and part of the ramus of the mandible. It is known as the parotid gland. এই জায়গাটায় থাকে parotid gland. And below the hair, এইখানটায় there is another gland is present known as the submandibular gland. আর ঠিক জিভের নিচে থাকে সাবলিঙ্গুয়াল গ্ল্যান্ড। সো দিস ইজ আ গ্ল্যান্ড, দিস ইজ দ্য প্যারোটিড গ্ল্যান্ড। জাস্ট প্যারোটিড গ্ল্যান্ডের পেছনেই রয়েছে দেখবে এক্সটার্নাল অ্যাকুস্টিক মেটাস, স্টাইলয়েড প্রসেস এটসেট্রা। এরপরে যেটা অ্যান্ড কম্পিটেন্সিতে রয়েছে স্টার্নিক্লিডোমাস্টয়েড মাসল। ডিটেলস তোমরা দেখবে, ইফ ইউ ওপেন ইউর বুকস ইউ উইল ফাইন্ড এভরিথিং অ্যাবাউট দ্য স্টার্নিক্লিডোমাস্টয়েড মাসল, ভেরি ইম্পর্টেন্ট কি মাসল of the. Why it is called sternocleidomastoid? Sterno means sternum, cleido means clavicle, and mastoid, mastoid process. So it is called the sternocleidomastoid, but better term would be sternocleidomasto-occipitalis, যদি muscle বলা হতো, কারণ it is also attached to the occipital bone also. যাকে বলছি না। So when we read a muscle, what we read? Origin, insertion, nerve supply, action, and if possible some of the important relations. And here the, for example, inferior extremity, you know, the gluteus maximus muscle is important. আমরা জেনে যাই, কোশ্চেন থাকে, what are the structures found under the gluteus maximus? এখানে কোন মাসলটাই থাকে? deltoid. Structures under the deltoid, এখানে সেই রকম একটাই মাসলের স্ট্রাকচারস আন্ডার পড়তে হয়, that is the sternocleidomastoid. Because very important structures are present and clinically you have to know it. Sternocleidomastoid origin below and insertion above. Clavicular head. Origin by two heads, sternal head, clavicular head. Sternal head origins from the lateral part of the anterior surface of the upper anterior and upper surface of the manubrium sterni. দেখো এটা হচ্ছে manubrium sterni এর anterior surface, তার upper part. So একটু laterally, one on either side. আমরা একটা সাইড বলছি, it arises from the upper part of the anterior surface of the manubrium sterni. Clavicular head from the middle 1/3 of the superior surface of the clavicle, and these two heads ultimately deeper and sternal head is superficial. Then it proceeds upward and it is attached. So insertion attached to the mastoid process, then the superior nuchal line, lateral 2/3 of the superior nuchal line. পরে আবার ডিটেলসে পড়বে। সো অ্যাটাচড ইজ অ্যাভাব। কোথায় অ্যাটাচ করছে? যার জন্য হোয়াট আই এম টেলিং বারবার, আই হ্যাভ রিপিটেডলি শো ইউ দ্য external occipital protuberance and superior nuchal line, inferior nuchal line, etc. So next picture ta dekhi. So this is the sternal head, the clavicular head joined together. Picture in cadaver you will see in your dissection that you can see the sternal and clavicular head, thin person, well built person. This is the sternocleidomastoid. So insertion is the mastoid process, upper part of this and lateral 2/3 of the superior nuchal line. Finished. Origin, insertion, nerve supply. Nerve supply is very important. It is supplied by the motor supply, মানে যেটা অর্ডার করে স্টার্নোমিটার ম্যাস্টয়েডকে অ্যাকশন করবে। মোটর সাপ্লাই ইজ বাই দ্য স্পাইনাল এক্সেসরি নার্ভ। 11th cranial nerve, আমরা জানি cranial nerve থাকবে, you will read first cranial nerve, first is the olfactory, second is the optic. Similarly, 11th cranial nerve is known as the accessory nerve. Accessory nerve, why accessory? It is said that the accessory to the vagus. Accessory nerve has got two components. One is the cranial accessory, another is the spinal accessory. Spinal accessory obviously show the lower part, and cranial accessory supply the upper region and the head neck. ছেড়ে দাও, পরে আসবো। So it is mainly supplied by the spinal accessory nerve, spinal part of the 11th cranial nerve, and proprioceptive sensation. Proprioceptive sensation মানে কি? By which the muscle, even in I not giving any knowing that my deltoid muscle is what is doing, but still I know my deltoid muscle in relaxed condition. My gluteus maxima muscle is in just acting to make not in acting, but if we do it even in dream, in your sleep you also know this muscle is acting, and this muscle sense whether the muscle is acting or not, whether the muscle is contracting or not, whether the muscle is relaxing or not, it is known as the muscle proprioception. This muscle proprioception is taken by the cervical C2 and C3 nerve. So it has got a dual supply, but motor supply is one. যদি C2 C3 nerve damage হবে, muscle sense lost হবে, কিন্তু motor activity we can do the action. So just আমি elaborate করলাম. So what is the nerve supply? Motor supply is the spinal accessory nerve, and proprioception or sensory supply by the C2 and C3 nerves. The main action, sternocleidomastoid can act both singly, that's mean only on the right side it is acting, left side is not acting, or left sternocleidomastoid is acting and right is not acting. So it is known as the unilateral action, and also both the muscle can act together, both right and left acting as a unison, acting synchronously. When the sternocleidomastoid acts unilaterally, one side, it rotates the symphysis minti to the opposite shoulder. দেখো হাত দাও, দেখবে এই মাসল স্টিফ হয়েছে, এই মাসল রিল্যাক্স। দেখো রাইট সাইডের মাসল স্টিফ হয়ে গেছে, মানে ইট ইজ অ্যাক্টিং, and chin is rotated towards the opposite shoulder. এই দিকের মাসলে হাত দাও, যেদিকে chin rotate, when in which direction the chin is rotating, it is muscle is relaxed. So when right sided sternocleidomastoid is acting, the chin unilaterally, chin will go towards the left side. It is known as the chin. আরেকটা কি হতে পারে? When right sided action, the side of the neck touch the shoulder. This is the unilateral action. এদিকে করলে এই বা এই। Bilateral action. Bilateral action is very important. Especially it is important in two things. When from the sitting, not sitting, from the sleeping region, one can raise the head. এই যে উঠলো হেডটা, then the bilateral action of sternocleidomastoid is needed. আর একটা more important, ভিড়ের মধ্যে আমি শর্ট হাইট সামনেও রয়েছে, এরকম করে দেখতে চাইছি টপকে, then both the sternocleidomastoid is absent for peeping up. So these are the actions of the sternocleidomastoid muscle. কেন বলছি short notes come, so you have to write in this fashion. Details জানার দরকার নেই, দু তিনটে রিলেশন জেনে রাখবে। এখন একটু it will look like a Hebrew to you, but when you go to the most important relation, the superficial fascia platysma রয়েছে, ওগুলি বাদ দিয়ে external jugular vein, it crosses the sternocleidomastoid from the medial to the lateral side. External jugular vein is formed near the angle of the mandible, এই জায়গাটায়, by joining the posterior auricular vein and posterior division of the retromandibular vein. Details হয়ে যাবে, নিয়ে চিন্তা করো না। Then ultimately it goes down and here it pierces the deep fossa, superficial vein. So it lies in the superficial plane, but it drains to the subclavian vein. Ultimately, it terminates in the subclavian vein, which is in deeper plane. So it must pierce the deep fossa here, supraclavicular fossa or greater suprafascia, and drain into the subclavian vein. This is the external jugular vein. এছাড়াও নার্ভস, গ্রেটার অরিকুলার নার্ভ, লেসার অক্সিপিটাল নার্ভ, ট্রান্সভার্স সার্ভাইকাল নার্ভ and clavicular nerve. These are the important superficial relations of the sternocleidomastoid muscles. External jugular vein, nerves of the cervical plexus, greater auricular, lesser occipital, এই এতে হয়ে যাবে এক্ষুনি ফ্রাইডেতে, ট্রান্সভার্স সার্ভাইকাল নার্ভ and supraclavicular nerve. Deep relation মনে রাখা বহুত, মানে all the structures of the neck lying deep to the sternocleidomastoid. যেরকম অ্যাবডোমেন ওপেন করলে গ্রেটার ওমেন্টাম এই ট্রান্সভার্স কোলনের পরে গ্রেটার ওমেন্টাম আর ট্রান্সভার্স কোলন পুরো ঢেকে রেখে দেয়, similarly sternocleidomastoid and trapezius almost cover all the structures of the neck. তার মধ্যে ইম্পর্টেন্ট হচ্ছে sternocleidomastoid এর ডিপ রিলেশন। Or here the sternocleidomastoid, in this picture you remove the sternocleidomastoid and throw it away, so that the deep relation muscle is কি থাকছে, deep bones, mastoid process, most important bony mastoid process, and upper part of the mesenteric. Most important arteries is the, you have idea about that. From the arch of aorta, common carotid artery arises. This common carotid artery at the upper border of the thyroid cartilage, it is the thyroid cartilage, it divides into two divisions. External jugular, peculiarly external jugular is lying more anteriorly, and internal jugular. দেখতে পাচ্ছ সবাই এটা, এই this is the common carotid artery. Here it divides into external jugular artery and internal jugular artery. Internal jugular artery goes up to enter the cranial cavity, and there is no branch it gives in the neck. Internal jugular artery কোনো branch নেকে দেয় না, and external jugular artery gives multiple branches in the neck. And this is the told just on, it is the external jugular vein. Here it is the most important vein, internal jugular vein. And just এখানকার নার্ভ আছে, নামছে ভেগাস নার্ভ। আমরা মেসারোমেন্টামে যেরকম পড়েছিলাম যে ডাক টু দ্য রাইট, ডাক হেপাটিক আর্টারি আর পেছনে পোর্টাল ভেন পড়েছিলাম তো। মানে ডাক আর্টারি এন্ড পেছনে পড়ে ঠিক এইখানে এরকম থাকে। কি কি থাকে? ইন্টারনাল জুগুলার আর্টারি, ইন্টারনাল জুগুলার ভেন এন্ড পেছনে থাকে ভেগাস নার্ভ। And these three things are covered by a deep fascial slit covering. ওদেরকে একটা কভারিং দেওয়া হয়েছে, এনভেলপ করা হয়েছে, এবং সেই কভারিং, the name of this covering is called carotid sheath, not the external jugular artery. ভুল করবে না, এক্সটার্নাল জুগুলার আর্টারি পিয়ার্স করে বেরিয়ে চলে আসে। ইট ইজ নট এ কন্টেন্ট, জাস্ট ইনিশিয়াল পার্ট ইজ এ কন্টেন্ট, বাট the greater part of external jugular artery is outside the carotid sheath. তাহলে carotid sheath এর contents কি? Internal jugular artery, internal jugular vein and vagus nerve, and upper part এ কয়েকটা 9, 11 and 12 নার্ভ থাকে, পরে আসবো carotid sheath যখন পড়বো। আর internal jugular vein এর carotid sheath এর উপরে একটা ইম্পর্টেন্ট, carotid sheath এর anterior রিলেশনে ভেরি ইম্পর্টেন্ট একটা নার্ভ প্লেক্সাস থাকে, তাকে বলা হয় আনসা সার্ভাইকালিস, পড়বে। এছাড়াও থাকে অ্যালং দ্য ইন্টারনাল জুগুলার ভেন লিম্ফ নোডস, ডিপ সার্ভাইকাল লিম্ফ নোড। এক্সটার্নাল জুগুলার ভেনে অ্যাকম্পানি করে সুপারফিশিয়াল সার্ভাইকাল লিম্ফ নোড, সেটাও কাম ইনটু দ্য সুপারফিশিয়াল রিলেশন। তাহলে লিম্ফ করছে। আর কি কি থাকছে? So many muscles are under the, of which the most important muscle is the omohyoid muscle. You have read in your scapula. Omohyoid muscle, এখানে একটু ডিটেইলস পড়তে হবে। এছাড়া কি মাসল থাকবে পরে পড়তে, যেমন স্প্রেনিয়াস ক্যাপিটিস, লঞ্জিসিমাস ক্যাপিটিস, এগুলি থাকছে। কেমন? নার্ভসের মধ্যে ফ্রেনিক নার্ভ, ভেগাস নার্ভ তো আগেই বললাম, 9, 10, 11 নার্ভ, all are coming to the relation to the posterior border of the sternocleidomastoid. বাস, sternocleidomastoid অনেক ডিটেলস বলে দিয়েছি, আর বেশি দরকার নেই, আসবে কিনা ঠিক নেই। নেক্সট অ্যানাদার ইম্পর্টেন্ট মাসল, খুব শর্টে বলবো, ইট ইজ কখনো এসেছে আমি শুনিনি, তো বলা যায় না, শর্ট নোট দিয়ে দিল। Muscle, you know, the trapezius muscle. Trapezius muscle of one side and trapezius muscle of the other side, when seen together, it looks like a trapezium. So it is called the trapezius. And it is the one side is the half trapezium. It is the half trapezium. A combined kore holo trapezium muscle. It has got a origin, insertion, nerve supply, action. Relation is not important. Red line টা হচ্ছে অরিজিন। Medial 1/3, lateral 1/3 নিয়েছিল sternocleidomastoid of the superior nuchal line। এবার medial 1/3 এ নিচ্ছে trapezius muscle। Then this is the external occipital protuberance. Then it goes downwards. Actually, it is destined to attach to the spine of the vertebra, কিন্তু পারছে না কেন? Spine of the vertebra is covered by ligamentum nuchae. So posteriorly it is attached to the ligamentum nuchae. So it takes origin from the ligamentum nuchae. Then spines of the T1 to T12 vertebra along with the supraspinous ligament. These are the origin of one side. Medial 1/3 of the superior nuchal line, external occipital protuberance, ligamentum nuchae, and spines of the T1 to T12 vertebra with supraspinous ligament. Insertion তোমরা বলবে, বলার কথা। কোথায়? insertion. পড়েছো সবাই, মনে পড়ছে না। Inner side of the it has got a upper fibers, trapezius has got a upper fibers, and lower fibers, the clavicle. Then attached to the medial border of the acromion process. Then to the upper border of the spine of the scapula. This is the origin of the anterior and middle fibers, and lower fibers attached to the triangular area near the spine, at the end of the spine of the scapula. So these are the insertion of the clavicle. Trapezius. Trapezius muscle is very important. Along with levator scapulae, it causes shrugging. আমরা যেরকম করি, shrug করছি, is an important, shrug করছি দুটো মাসল নিয়ে, levator scapulae and trapezius. Along with the rhomboids, it retracts the scapula. এই যে আমরা এরকম করছি, along with the rhomboids, it retracts the scapula. And third টা এবার তোমরা বলো, hints দিচ্ছি shoulder joint এ। থার্ডটা তোমরা বলো, টাইম দিচ্ছি। লোয়ার ফাইবারস কি করে? শোল্ডার জয়েন্ট মুভমেন্টে সাহায্য করে, কিভাবে? হাউ? Very important is the abduction of the shoulder. When we abduct, the undersurface of the acromion comes into the greater tuberosity of the humerus, and it cannot, further abduction is not possible. এই আমরা abduction করছি, it is the acromion process. It is the acromion process. When we abduct by the supraspinatus and deltoid, it causing abduction. When is 90 degree? The greater tuberosity of the humerus comes under the acromion. And the anterior muscle rotates the scapula. 30 degree rotates the scapula, medially rotate, and we can abduct up to 180 degree. So it helps in the abduction of the shoulder by rotating the scapula in the later part of the abduction. Very important. মনে রাখতে হবে এই কয়েকটা জিনিস। Sternocleidomastoideর একটা অ্যাকশন বলতে ভুলে গেছি। It is an important muscle of forced inspiration. যখন আমরা জোরে নেই, sternocleidomastoid acts as a secondary muscle of respiration. So this is the next muscle is the omohyoid muscle. Very important muscle. Omohyoid is a clear muscle. It has superior belly and inferior belly. Superior belly and inferior belly. Inferior belly origin takes attached to the suprascapular notch and the superior border of the supraspinous ligament. Scapular superior border মনে আছে? একটা নচ আছে, suprascapular notch ওইখান থেকে অরিজিন নিচ্ছে, superior border থেকে। And border of the body of the hyoid bone, omohyoid. Omo means shoulder, hyoid means hyoid bone. So it is arising from omo, is clavicle, and hyoid, lower border of the body of the mandible. This is the superior belly and it is the inferior belly, and both the belly joined together by a midline tendon. It is the insertion. এরকম কোনো insertion নেই. They are joined together in a midline tendon. under the sternocleidomastoid, and this is known as the intermediate tendon of the omohyoid muscle, and it remains fixed either by extension by a pulley, fibrous pulley দিয়ে এটাকে ফিক্সড করা রয়েছে যাতে এটা বেশি নড়াচড়া না করতে পারে, কারণ অরিজিনে বনি ইনসারশন তো নেই, সুতরাং মাসল অ্যাকশন করলে উপরে উঠে যাবে। সুতরাং এইটাকে একটা fibrous pulley দিয়ে এটা অ্যাটাচ করা রয়েছে, remain fixed, and this fibrous pulley, some say it is derived from the posterior layer of the clavipectoral fossa, some say it is derived from the investing layer of the deep cervical fossa, some say both। ছেড়ে দাও, তাহলে এইটা গেল next another important muscle similar to anterior belly and not superior inferior, omohyoid এর ছিল superior and inferior belly, here it is the anterior belly and digastric yellow color. This is the posterior belly of the digastric muscle, and both are connected by fibrous pulley, and this middle part we call the intermediate tendon, and this fibrous pulley is attached to the hyoid bone so that it is remain fixed। Anterior digastric fossa রয়েছে, এখান থেকে অরিজিন নেয়, আর posterior belly takes origin from the mastoid process of the temporal bone, পরে পড়বে inner side, so it is the digastric muscle। নাসলের নামগুলি লাগছে, কালকে লাগবে। And another muscle along with the digastric, posterior belly of the digastric, this is the intermediate tendon, and it is the fibrous pulley attached to the bone. There is another muscle from the styloid process to the hyoid bone, it is known as the stylohyoid muscle, parallel to the posterior belly of the digastric। নামগুলি শুধু মনে রাখবে, ডিটেলস তোমাদের কেউ জিজ্ঞেস করবে না। ইটস টু ইম্পর্টেন্ট মাসল হেয়ার, কিছুটা তোমরা জানো, স্টার্নামে পড়েছে স্টার্নোহাইয়েড and sternothyroid muscle, hyoid muscle and sternohyoid muscle. It takes origin from the posterior surface of the manubrium sterni and attached to the lower border of the hyoid, and it goes about parallel to the superior belly of the omohyoid. When you cut the sternohyoid muscle, you will find the sternothyroid muscle. So sternothyroid muscle is deeper, হতেই হবে, কারণ it process over the thyroid cartilage to attach to the hyoid bone, and this sternothyroid muscle takes origin from the manubrium sterni and attached to the thyroid cartilage. So two midline muscle, one on either side, এইখানে থাকে, শুধু নামগুলি জানবে। sternohyoid superficial muscle, deep to it sternothyroid। sternohyoid muscle এর এক প্লেনে কে থাকে? superior belly of omohyoid। This is the sternohyoid muscle। তাহলে এবার যদি আমি করি, it is the muscle, this is the sternohyoid muscle, superior belly of the omohyoid, আর it is the digastric muscle, stylohyoid muscle। এইগুলি কালকে লাগবে প্লিজ, তাহলে আমি এগোতে পারবো না, এই মাসেলগুলি তোমার লাগবে আমার। This is the sternothyroid muscle। There is another muscle known as the thyrohyoid muscle from the thyroid cartilage to hyoid bone। এইটুকুনি জানলেই হবে, এগুলি ডিটেলস তোমাদের ফাইনালেও বেশি জানতে হবে না, কেমন? জাস্ট নামগুলি জেনে রাখবে। এইখানে এই আরেকটা ইম্পর্টেন্ট মাসল, এইখানে হাত দাও, এখানে যদি স্কিন সুপারফিশিয়াল ফসা কাটি, এই জায়গাটা একটা দুপাশে দুটো মাসল আছে, তাকে বলে মাইলোহাইয়েড মাসল। দিস ইজ দ্য মাইলোহাইয়েড মাসল। মাইলোহায়োয়েড মাসল। কেমন? জাস্ট নামগুলি মনে রাখো, কালকে বুঝতে পারবে কেন বলেছিলাম। আরেকটা মাসল রয়েছে, তাকে বিরক্ত করবো না। এই কয়েকটা মাসেলের আইডিয়াটা কোনটা কোথায় থাকে, তাহলে উপরে থাকছে মাইলোহায়োয়েড হায়োগ্লসাস মাসল, স্টার্নোহায়োয়েড স্টার্নোথাইরয়েড, ডাইগ্যাস্ট্রিক মাসল এইখানে, ওমোহায়োয়েড এখানে, আর সবার উপরে স্টার্নোক্লিডোমাস্টয়েড আর পেছন দিকে ট্র্যাপিজিয়াস। আচ্ছা, আইডিয়াটা দরকার। দিস ইজ দ্য ট্র্যাকিয়া, দিস ইজ দ্য ল্যারিংস, থাইরয়েড কার্টিলেজ অ্যান্ড প্রিকট কার্টিলেজ, ইনসাইডটা হচ্ছে ল্যারিংস, তার নিচেই হচ্ছে ট্র্যাকিয়া। ট্র্যাকিয়ার পিছনে রয়েছে, ওপরে রয়েছে ফ্যারিংস অ্যান্ড ল্যারিংস। ফ্যারিংসের তিনটে মাসল পরপর রয়েছে, সুপিরিয়র কনস্ট্রিক্টর, মিডিল কনস্ট্রিক্টর অ্যান্ড ইনফিরিয়র কনস্ট্রিক্টর। খুব তাড়াতাড়ি যাচ্ছি, নাহলে শেষ হবে না, এগুলি আর দরকার নেই এখন। আচ্ছা, জাস্ট একটা লাইন বলি, আজকে ছেড়ে দিচ্ছি। আগেই বলেছি, we divide the area into number of areas. Broadly, our anterior and lateral surface of the neck we divide into two triangles. One is known as the anterior triangle and one is known as the posterior triangle. Why it is anterior? Why it is posterior? Because anterior triangle is anterior to the sternocleidomastoid muscle and posterior triangle is posterior to the sternocleidomastoid. সুতরাং এইটা midline base of the mandible, এই যে ট্রায়াঙ্গেলটা, it is known as the anterior triangle, and sternocleidomastoid and it is the trapezius muscle, and clavicle middle third clavicle এর উপরে যে ট্রায়াঙ্গেলটা রয়েছে সেইটাকে বলা হয় posterior triangle muscle। তাহলে আমরা anterior triangle কতটা, posterior triangle কতটা বললাম, and anterior triangle and posterior triangle is a large area. So we subdivide the anterior triangle and posterior triangle into number of sub triangles. কালকে আসবো। সুতরাং this is the anterior triangle, কেমন? এরপরে আমরা কালকে ডিপ সার্ভাইকাল ফাসাতে চলে যাব আর anterior triangle আর posterior triangle এ চলে যাব। Thank you.
Today we are going to perform a test called Fauci test. Okay, Fauci test generally we perform for identification of bile pigment in urine sample. Okay, now in your copy what you write in the procedure, most of the students just simply take the 5 ml of urine, then add few drops of 10% barium chloride. After then there is formation of precipitate, okay, which is settled down at the bottom of the test tube. Then with the use of filter paper we filter the sample. After then we drop few drops of Fauci's reagent on the filter paper. Then in observation there is develop of colors. Color means what? It is green to yellow, yellow to green color, that is pista color. पिस्ता देखा, पिस्ता का कलर होता है वैसा कलर डेवलप होगा, पिस्ता कलर इज डेवलप एंड दिस इज फाइनल, देयर इज bile pigment is present. What the meaning of bile pigment? That is bilirubin is present. Okay, basically this is the oxidation reaction, the bilirubin is oxidized. So you write, all of you write the procedure, actual procedure what I tell you, write it, all of you take the copy and write it the procedure. Right procedure of Fauci test, take 5 ml of urine plus add करके लिखेंगे, add 1 drop of solution of 5 ml barium chloride, 5 ml barium chloride, 5 ml, then add 5 ml 10% barium chloride solution, then add 5 ml 10% barium chloride solution. mix it, then heat, after then cool, heat and cool down the test tube, and cool down the test tubes, then filtered with filter paper, then filter the solution with filter paper, filter the solution with filter paper, filter the solution with filter paper, and finally add 1 to 2 drop of Faucet's reagent on filter paper. 1 to 2 drop of Faucet's reagent on filter paper. On filter paper, okay? Dry it. Last में लिखना, dry the filter paper. Dry it the filter paper class. Observation में yellow to green color is developed. ब्रैकेट में लिखेंगे पिस्ता, PISTA. Yellow to green ब्रैकेट में पिस्ता color is developed. This is your observation. Okay? अब सुनो सब लोग, यहाँ देखो, while you performing the test, जब आप perform करेंगे, first of all you take 5% ml of urine sample in the test tube, then you add 1 drop of magnesium sulfate solution, then add 5 ml 10% barium chloride, mix it, then heat it. What happens with this process? The bilirubin, which is the biliverdin which is present in the urine sample, become precipitate and settle down at the test tube in the form of precipitate. Okay? In the next step, what will you do? You take a funnel. In the funnel, you fix the filter paper, and after fixing filter paper, you filter the solution. Okay? After filtering the solution, the precipitate which is settled down at the bottom comes over the filter paper. Okay? After then, you firstly dry the filter paper. हवा में थोड़ा सा उसको ड्राई करेंगे, थोड़ा खिड़की से बाहर थोड़ा धूप हल्का सा मॉइस्ट थोड़ा सा उसका ड्राइनेस आ जाए. उसके बाद हम क्या करेंगे, केयरफुली 1 to 2 ड्रॉप ऑफ Faucet's reagent उसके ऊपर फिल्टर पेपर के ऊपर डालेंगे. ठीक है? Then there is, you will see the boundary of your precipitate become green color observed, and it is your final observation for the presence of bipedal. समझ में आया? नहीं समझ में आया सर से और सबसे पूछ लेना, केयरफुली ये प्रैक्टिकल करो. ठीक है?
पाँच मिनट रुको, पूरा 5 मिनट.
Okay, so to start with, write it down. What is posterior abdominal wall? So these thing you have come across many times during the dissection of the abdomen. Okay, so tell me what are the posterior relation? Keep quiet everyone. What is the posterior relation of abdomen or posterior relation of the kidney? Tell me how many muscle? Just remember the posterior relation of kidney. Ki pabi bol? First muscle is the diaphragm. Okay, diaphragm. So write it down. There are four muscle. Number one is diaphragm. Second one is psoas major. Okay, psoas major এর origin কোথা থেকে কোথায় বলতো? T12 to L5. Okay, পুরো lumbar along with T12. Okay, আর কি muscle থাকে? Quadratus, lumborum. Okay, and just beside that transversus abdominis. Okay, and another muscle here it will come, that is known as iliacus. মনে থাকবে, there are 5 muscle. So 5 muscle কি কি? First one is diaphragm, then psoas major, quadratus lumborum, transversus abdominis, last one is iliacus. Okay, এছাড়া আর কি পাবি? So there are how many nerves? এটা তো চারটে মাসেল গেল posterior, কিন্তু এখানে 5টা মাসেল আছে posterior abdominal wall এ। আর কি কি নার্ভ আছে বল? Which 3 nerves? তাই তো 3টে নার্ভ আছে। কেন? posterior relation of kidney পড়ানো হয়ে গেছে তো, তাই না? সেগুলোই তো posterior abdominal wall এ থাকবে, তাই তো? তাহলে কি থাকবে বল? 3টে, write it down. First one is subcostal, T12, subcostal, first one. Then second one is ilioinguinal, iliohypogastric. Very easy, there are 3 nerve. Okay, আর কি কি main structure পাবি? Abdominal aorta and its branches. ঠিক আছে? Inferior vena cava and its branches and its tributaries. Okay, inferior vena cava and its tributaries. আর কি থাকবে? thoracic duct along with cisterna chyli. কেমন appearance হয় রে thoracic duct এর? appearance টা কেমন? how does it look? have you seen the thoracic duct? বহুবার দেখেছিস posterior abdominal wall এ। beaded appearance. Okay, this is the key point for the thoracic duct. আর additionally কি পাবে? sympathetic trunk. Okay, write it down. Another structure is sympathetic trunk. Okay, আর কি কি পাবি? আরেকটা হচ্ছে lymph nodes. So which type of lymph nodes? Pre-aortic, para-aortic lymph nodes. Okay, so these are the type of lymph nodes you will get. So see, these are the structure, তাই তো? So what are the thing you could see? এটা কি বল? এটা হচ্ছে diaphragm. Okay, so here is the piercing. 3 thing is piercing. কি কি pierce করছে বল? esophagus at the level of T10, inferior vena cava at the level of T8 and aorta at the level of T12, তাই তো? তো diaphragm আছে, and additionally if you see one by one muscle, so first muscle is diaphragm, then second muscle কোনটা? psoas major রে? হ্যাঁ, কোনটা psoas major? পিছনেরটা, because see it has how many heads? Okay, then what is this? psoas minor, and posterior to that এটা কি? iliacus, then quadratus lumborum. আর এই সাইডটা anterior সাইডটা তো দেখা যাচ্ছে না abdomen-এ, কি পাবো? transversus abdominis. Okay, so total this many nerve you will see. Okay, then diaphragm, you know everything about diaphragm. So tell me the attachment, lower attachment of diaphragm. lower attachment এ কি কি থাকে? এই পিকচারটা দেখেই বলতে পারবি। দেখ, এটা 3টে অরিজিন আছে, তাই তো? এটা কি অরিজিন? sternal attachment, আর আরেকটা কি অ্যাটাচমেন্ট আছে? costal attachment, আরেকটা vertebral. Very good. These are the 3 attachment of the diaphragm. So where does it extend? কোথাও দিয়ে extend করে? So there are median arcuate ligament. Okay, তার বিসাইডে কি পাবো? medial arcuate ligament, আর তার বিসাইডে কি পাবো? lateral arcuate ligament. So these are all things you will see in the posterior abdominal wall. Okay, easy to identify, and you will all see the hiatus, different hiatus present on the diaphragm. Okay, so now coming to the origin of diaphragm. So this thing you have studied. Okay, so see which are the other 2 muscle coming on the lower surface, তাই তো? তো lower surface এ প্রথমে কি পাবে? psoas major, তাহলে এটা কোন arcuate ligament থেকে আসছে? medial arcuate ligament. আবার quadratus lumborum আসছে কোথা থেকে? on the lateral arcuate ligament. Okay, So these are the important thing. And what is this? Abdominal aorta. So could you tell me the branches of abdominal aorta? কতগুলো আছে? So which are giving to the gut? Gut কে কে দিচ্ছে? celiac trunk, superior mesenteric, inferior mesenteric. These are known as anterior branch. তারপরে আসছে তোর lateral branch. Lateral branch কি কি আছে? So by the side bilateral branch কোনগুলো? Bilateral gonadal হবে আর renal হবে, suprarenal হবে। ওকে, আর পিছনে কি কি পাবো? lateral যেটা তুই বললি যে lumbar পাবো, sacral পাবো। আর লাস্ট এর টার্মিনাল ব্রাঞ্চ কি? দুটো, তাই না? কমন ইলিয়াকটা দুটোতে ভাঙছে, রাইট এন্ড লেফট। টার্মিনাল ব্রাঞ্চ হচ্ছে সবসময় কমন ইলিয়াক। ওকে, কমন ইলিয়াকটা ফার্দার ডিবা এওটা আবার বলবো। So this thing you have to study. You have, if suppose posterior abdominal wall comes, you have to say about the diaphragm. Understood? So I'm just giving these slides. So see, this is the different thing. So rather than that, what are the thing you could see? See, what is this? This is the arcuate ligament. So just beside that, what is this? These are known as sympathetic trunk. ঠিক আছে, sympathetic trunkটা কিন্তু both side এ রান করবে। ওকে, কতগুলো নার্ভ আছে রে আমাদের? স্পাইনাল নার্ভ কতগুলো আছে? 31। সার্ভাইকাল কটা? 8, thoracic 12, then lumbar 5, sacral 5, coccyx 1, তাই তো 31 pairs। সো কতগুলো থাকবে সিম্প্যাথেটিক ট্রাঙ্কে? সিম্প্যাথেটিক ট্রাঙ্কটা ভালো করে পড়তে হবে। রাইট ইট ডাউন। হোয়াট ইজ গ্যাংলিয়ন ইম্পার and how many numbers of nerve fibers are there? গ্যাংলিয়ন ইম্পার, যেমন একটা লকেট হয় না, লকেট হয় একটা হাড়ের। ওকে, সো দিস থিং, দিস চেইন ইজ দ্য সিম্প্যাথেটিক ট্রাঙ্ক and what is ganglion impar? That is the locket. Okay, so study the ganglion impar, 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 ganglion impar. So এইভাবে এটা পুরোপুরি যাবে। and what is the number of this sympathetic trunk? sympathetic ganglion পড়েছিলি, it is same like the autosome. autosome কতগুলো থাকে? 22 জোড়া, 22 জোড়া, তাই তো? 44টা, তাই তো? আর একটা থাকবে তোর গ্যাংলিয়ন ইম্পার। বুঝতে পারলি? গ্যাংলিয়ন কি করে তৈরি হয়? 8টা বললাম তো। সার্ভাইকাল গ্যাংলিয়নটা লেখ। সার্ভাইকাল ইজ 4, C1 to C4, C1 to C4 একটা গ্যাংলিয়ন তৈরি করবে, C5 C6 একটা গ্যাংলিয়ন তৈরি করবে, C7 C8 একটা গ্যাংলিয়ন তৈরি করবে। বোঝা গেল? 4 2 2 সার্ভাইকাল C1 to C4, ঠিক আছে? এটা একটা গ্যাংলিয়ন তৈরি করলো। দেন নেক্সট ওয়ান ইজ C5 to C6, C5 6, দেন লাস্ট এরটা হবে 7 8। বোঝা গেল? এটা সার্ভাইকাল তৈরি করলো। থোরাসিক কটা তৈরি করবে? রিমেনিং সব কটা দুটো দুটো করে তৈরি করবে। বোঝা গেল? এবং লাস্টে গিয়ে কক্সিসে হয়ে যাবে একটা। ঠিক আছে, একটাই জানিস, একটাই নার্ভ ফাইবার থাকে, সেটাকে কি বলবো আমি? গ্যাংলিয়ন ইম্পার। বোঝা গেল? So now coming to the psoas major. So it arises from T12 to L5 vertebra. Okay, already I have discussed. Tell me the insertion of iliopsoas. Lower limb e পড়েছিস? Which trochanter? Lesser trochanter. Lesser trochanter. Nerve supply কি হবে? psoas major এর nerve supply কি লেখা আছে? So see, this is the psoas major, তাই তো? So psoas majorটা এটা যদি এখানে এসে ইনসার্ট করছে, লেসার ট্রোকেন্টার ইনসারশন কি হবে? নার্ভ সাপ্লাই কি হবে বল? না, লাম্বার প্লেক্সাসে L1 L2 যেটা ইলিওইঙ্গুইনাল ইলিওহাইপোগ্যাস্ট্রিক ওর পাশ থেকেই তো বের হচ্ছে, তো ইলিওহাইপোগ্যাস্ট্রিক এটা দেবে। ঠিক আছে, psoas major কেও দেবে, quadratus lumborum কেও দেবে। So what about the quadratus lumborum? It is quadrilateral in shape, that's why it has given the name. আর কোথায় কোথায় থাকবে দেখ, এই লিগামেন্টটা আগের দিনও বলেছি, that is known as iliolumbar ligament. Okay, so additionally adjoining part of iliac crest and tip of transverse process. iliac crest থেকে অরিজিন হয় জানিস, তাই তো? কোনটা ইনসারশন হবে অ্যাবডোমিনাল মাসল? একটা মাত্র ইনসারশন হবে, কোনটা? iliac crest, iliac crest of hip bone, external oblique, তাই না? এক্সটার্নাল অবলিক ইনসারশন হবে। আর তো ট্রান্সভার্সাস অ্যাবডোমিনিস ইন্টারনাল অবলিক অরিজিন হবে, তাহলে এইটা কোয়াড্রেটাস লাম্বোরামটাও আসছে অ্যাডিশনালি টু দিস ওয়ান, ঠিক আছে, অরিজিন নিচ্ছে। ওকে, সো সি দিস ইজ, এটা মনে রাখবে psoas major is T12 to L5 throughout. Okay, and that's beside that you have quadratus lumborum. And what is this muscle? Iliacus. Okay, so these are the three muscle you will see. Okay, so iliacus already you know, nerve supply ki hobe, femoral nerve, directly femoral nerve debe, action ki, action is very much important. Iliacus er ki action hobe, flexion of hip while the knee is flexed. Okay, আরেকটা কি, it flexes the trunk on thigh, ঠিক আছে, when you are kneeling down, ঠিক আছে, তখন কোন মাসেল অ্যাক্ট করছে, ইলিয়াকাস, আন্ডারস্টুড। সো দিস আর দ্য থিং মাসেল ফাসা অফ দি অ্যাবডোমিনাল ওয়াল। এবার ফাসাতে আসি, কতগুলো ফাসা থাকে, সবথেকে ইম্পর্টেন্ট ফাসা হচ্ছে থোরাকোলাম্বার ফাসা, ঠিক আছে, মেক ওয়ান লং নোট অলসো, থোরাকোলাম্বার ফাসা অ্যালং উইথ ডায়াগ্রাম। ওকে, সো অ্যাডিশনালি প্রতিটা মাসেলকে একটা করে ফাসা ক্লোজ করবে, কে সোয়াস ফাসা হবে, ইলিয়াকাস ফাসা হবে, ঠিক আছে, বাট মেইন ফাসা ইজ আ থোরাকোলাম্বার ফাসা। ওকে, অন দ্য পোস্টেরিয়র অ্যাবডোমিনাল ওয়াল। সো সি, write it down, thoracolumbar fascia. So it is a deep fascia, covers and encloses the muscle on the back, covers and encloses the muscle on the back. Okay, so lumbar part of deep fascia lies in interval between the iliac crest and the 12th rib. এই ফাসাটার কোথা থেকে হচ্ছে, লাম্বার পার্ট, দেখ কতগুলো পার্ট আছে, এটা হচ্ছে লাম্বার পার্ট, যেটা ইন্টারভাল বিটুইন দ্য ইলিয়াক ক্রেস্ট এন্ড 12th rib। 12th rib হচ্ছে ফ্লোটিং রিব, ওর সাথে আর ইলিয়াক ক্রেস্টের মাঝে অরিজিন নিচ্ছে থোরাকোলাম্বার ফাসা, ঠিক আছে। এটার কতগুলো পার্ট আছে, আই উইল কাম অ্যাক্রস। সো সি, দিস ইজ দ্য থোরাকোলাম্বার ফাসা, তাই তো, ভার্টিব্রা পড়ার সময় পড়েছিস, কোন ভার্টিব্রা পড়ার সময় পড়েছি, লাম্বার ভার্টিব্রা, তাই তো। সো ইফ ইউ সি দ্য অরিজিন এন্ড ইনসারশন, আমি কি বলেছিলাম, প্রথমে কোথা থেকে অরিজিন নিচ্ছে, এটা কি ভার্টিব্রাল বডি, তাই তো, প্রথমে কোন মাসেলকে ক্লোজ করছে, সোয়াস মেজর, এটা কে ক্লোজ করছে, অ্যান্টেরিয়র ল্যামিনা, ঠিক আছে, আবার মিডল ল্যামিনা কাকে ক্লোজ করছে, কোয়াড্রেটাস লাম্বোরাম, আর পোস্টেরিয়র ল্যামিনা এনক্লোজেস ট্রান্সভার্সাস অ্যাবডোমিনিস, ঠিক আছে। এই ডায়াগ্রামটা কিন্তু যদি আসে, ইউ হ্যাভ টু ড্র, ওকে, along in details you have to say each and every 5 words of thoracolumbar fascia. Okay, so posterior layer, এবার এগুলো ভালো করে লিখ, posterior layer, it covers the back of erectus spinae. erectus spinae কোথায় থাকে, একদম spine of vertebra তে থাকে, তো এটা হবে, it extend from sacrum to the neck. Okay, and in the lumbar region it is very thick and attached to the lumbar spine. Okay, this is the posterior layer. Now coming the middle layer, middle layer বলেই দিয়েছি কোন মাসেল কে এনক্লোজ করছে, কোয়াড্রেটাস লাম্বোরাম, আর অ্যান্টেরিয়র এর মিডল ফাসা দুজনে মিলে কাকে করবে, দ্যাট ইজ দ্য সোয়াস মেজর, ঠিক আছে, অ্যান্টেরিয়রটা করবে সোয়াস মেজর। ওকে, নাও ফাসা ফর দ্য সোয়াস মেজর এন্ড ইলিয়াকাস, দুটো মাসেল কি আলাদা ভাবে ইট হ্যাজ গট সেপারেট ফাসা। ওকে, বোথ সোয়াস মেজর এন্ড দ্য ইলিয়াকাস। ওকে, so next one is, write it down, clinical anatomy, tuberculosis of thoracolumbar fascia. TB spine জানিস, তাই তো, কোথায় বেশি কমন হয় জানিস, লোয়ার thoracic and upper lumbar region। ওকে, যেখানে thoracolumbar fascia আছে। সো কি হয়, tuberculosis এ there would be pus formation। ওকে, এই পাসটা কোথায় যাবে, it will go to the psoas and iliacus fascia. So just write it down, pus form in case of tuberculosis in the thoracolumbar fascia used to go to the fascia of the psoas major and fascia of the iliacus. Okay, এটা যদি হয়, ধর fascia of psoas major আর iliacus কোথায় গিয়ে ইনসারশন হলো, লেসার ট্রোকেন্টার অফ দ্য ফিমার, তাহলে ওই এরিয়ায় কি হবে, সোয়েলিং হবে, ঠিক আছে, এবং এই সোয়েলিংটা অলরেডি মিস্টেকেন ফর ফিমোরাল হার্নিয়া। ওকে, সো রাইট ইট ডাউন, দিস সোয়েলিং ইউজ টু মিস্টেকেন উইথ দ্য ফিমোরাল হার্নিয়া। সো দিস ইজ এ কাইন্ড অফ ডিফারেন্সিয়াল ডায়াগনোসিস, বোঝা গেল, ফিমোরাল হার্নিয়া আর একটা হচ্ছে টিবি অফ thoracolumbar fascia। ওকে, সো দিস আর দ্য রিলেশন। সো এবার যদি তার কোয়াড্রেটাস লাম্বোরামের রিলেশন বলে, সো হোয়াট আর দ্য থিং ইউ উইল গেট, 3 নার্ভ পাবি, একটা হচ্ছে সাবকস্টাল, ইলিওহাইপোগ্যাস্ট্রিক, ইলিওইঙ্গুইনাল, আর কি কি পাবি, সোয়াস মেজর এন্ড মাইনর, আর কি কি পাবে? কোলন অ্যান্ড কিডনি। হুইচ কোলন? পোস্টেরিয়র অ্যাবডোমিনাল ওয়ালের কি কি রিলেশন হবে? পুরোটাই থাকবে, তাই না? অ্যাসেন্ডিং, ডিসেন্ডিং, ট্রান্সভার্স কোলন অ্যান্ড ইভেন ইনক্লুডেড দ্য প্যারাকোলিক গাটার্স। ওকে, সবটাই ইনভলভ থাকবে। আর পোস্টেরিয়রলি কে থাকবে? ইরেক্টাস স্পাইনি। ওকে, দিস ইজ নট দ্যাট মাচ ইম্পর্টেন্ট। Okay, iliacus. So this one is important. So iliolumbar ligament. Iliolumbar ligament. So this iliolumbar ligament is a strong ligament that passes from the tip of the transverse process of fifth lumbar vertebra. একমাত্র fifth lumbar vertebra যেটা কিনা তোর atypical lumbar vertebra, তাই না? তো সেটাতে অ্যাটাচ থাকবে to the posterior part of 1/3 inner lip of iliac crest. iliac crest এর কোথায়? posterior part 1/3 of the inner lip of iliac crest. এটা কিন্তু কালকে আমরা পেয়েছি pelvic cavity তে, তাই না? sacrotuberous sacrospinous এর সাথে এটাও পাওয়া গেছে, iliolumbar ligament. Okay, so this is one important. Next one is aorta, তাই তো? abdominal aorta. So they have shown. Tell me where does it open? It begins at the level of T12. তারপর celiac trunk কতই আসে? T12 এই চলে আসে celiac artery ইমিডিয়েটলি দেয়। তারপরে সুপিরিয়র মেসেন্ট্রিকটা L1 আর ইনফিরিয়রটা L3। ভেরি গুড। তো দিস আর দ্য আর্টারি। সো ওয়্যার ডাজ ইট এন্ড? কোথায় শেষ হয়? কোথায় বাইফার্কেশন হয়? L4। টার্মিনেটস, ওয়্যার ডাজ ইট টার্মিনেট? সেটা ইম্পর্টেন্ট। ওকে, L4 এ গিয়ে টার্মিনেট করবে aorta. So see, these are the typical aorta. So what are the thing you will see? These are giving the celiac artery, mainly celiac artery. Okay, additionally this is the superior mesenteric, inferior mesenteric. Okay, and this is the bifurcation. What about this? এই তিনটে কি কি বল? প্রথমটা কি হবে? suprarenal, তারপরটা হবে renal, তারপরটা হবে gonadal. Okay, these are the three branches. আর posteriorly কে কে থাকবে? sacral, তাই তো? median sacral যেটা পিছনের দিকে। Okay, so these are the branches of aorta. একটু লিখে নে। aorta কিন্তু লং কোয়েশ্চেন হিসেবে anything could come from aorta, ভীষণ ইম্পর্টেন্ট। and what is the clinical important? aneurysm of aorta. aneurysm of aorta মানে কি? what do you mean by aneurysm? so yeah, it would be dilated, যেমন ধর coarctation of aorta পড়েছেন আমরা। তো that would be sudden part would be dilated. okay, so dilated tortuous artery. So that is the aneurysm. aneurysm হলে কি হবে? ধর aneurysm হলো কারো, কোনো পেশেন্টের aneurysm থাকে, so what is the vulnerability? কি ক্ষতি হতে পারে তার? So there is a chance of rupture. Okay, which is a emergency condition. বুঝতে পারলি? কোনোভাবে রাপচার হয়ে গেলে সেটা কিন্তু emergency condition. Okay, so what are the artery? প্রথমে হচ্ছে celiac artery, superior mesenteric, inferior mesenteric. Then three lateral and visceral branches. So these are the suprarenal, renal, testicular or ovarian. Okay, so these are the lateral branches. Then other branches কি কি আছে? 5 lateral abdominal wall branches. Inferior phrenic, don't forget inferior phrenic, তাই তো? inferior phrenic আর 4 lumbar. inferior phrenic, 4 lumbar. আর লাস্টে টার্মিনাল ব্রাঞ্চ হচ্ছে, টার্মিনাল ব্রাঞ্চ you told. median sacral is also terminal branch. ঠিক আছে, মিডিয়ান স্যাক্রাল যেটা পুরো স্যাক্রাল প্রমোটারির উপর দিয়ে চলে গেল, ঠিক আছে, ওইটা একটা। আর তোর কমন ইলিয়াক, সেটা আবার ফার্দার ডিভাইড করছে এক্সটার্নাল এন্ড ইন্টারনাল ইলিয়াক। ওকে, সো হোয়াট ইজ সিস্টারনা কাইলি? সো ইট ইজ রাইট এন্ড লেফট লাম্বার ট্রাঙ্ক আন্ডার দ্য ডায়াফ্রাম। ওকে, সো একটু থোরাসিক ডাক্টটা বল। থোরাসিক ডাক্টটা কোন সাইডে থাকবে? where does it form? left side. Then it goes to, then used to cross to the right side. Okay, and it will join to the right lymphatic duct. And where does it drain? thoracic duct কোথায় ড্রেন করে? আরে টোটাল বডিতে কোথায় ড্রেন করে? দুটো ড্রেনেজ আছে না, একটা করবে thoracic duct আর একটা করবে তো রাইট lymphatic duct। হ্যাঁ বল। হ্যাঁ, থোড়াকো আমার। So thoracic duct is draining everywhere except the right side above the diaphragm. Okay, সেটা কি করবে? right lymphatic duct. Okay, so thoracic duct is collecting the lymph. Where does it go? কোথায় যাচ্ছে? টু দ্য লোয়ার অ্যাবডোমিনাল ওয়াল, লোয়ার পোস্টেরিয়র অ্যাবডোমিনাল ওয়াল। ওখানে দেখবি ক্যাডাভারে একটু এলিভেটেড পার্ট আছে। thoracic duct a beaded appearance where it has got elevated part, swelling, so that means cisterna chyli. Cisterna chyli মানে কি? It is a lake of lymph. Cisterna মানে হচ্ছে lake, okay, so it is creating the lake. So এটা already বলেছে, okay, about the cisterna chyli and the thoracic duct. So see, this is the, এটা cisterna chyli দেখতে পেয়েছিস, উপরে যেটা আছে সেটা কি thoracic duct, আর রাইট সাইডে কি আছে, এইদিকে ইনফিরিয়র ভেনা কাভা আছে। সো দিস ইজ হুইচ সাইড? রাইট সাইড। তো রাইট সাইডে এখানে কে থাকবে? রাইট লিম্ফ্যাটিক ডাক্ট আর থোরাসিক ডাক্ট দুটো মিলে এখানে তৈরি করলো সিস্টারনা কাইলি। সিস্টারনা কাইলির ইয়েটা খুব ইম্পর্টেন্ট, ভার্টেব্রাল লেভেল কোথায় হচ্ছে বল? ইয়া, বিকজ সি দা অ্যাটাচমেন্ট অফ ডায়াফ্রাম, ঠিক আছে, এটা T12, এটা L1, মেইনলি T12 and L1, ওকে। So it is having over there. আর কি কি পাবি additionally? এখানে কি দেখতে পাচ্ছিস? lymph nodes. How many type of lymph nodes? lymph nodes টা একটু লিখে নে। So কি কি type of lymph nodes? So many, whatever you studied. Okay, you have to say first কি পড়বি? celiac lymph nodes, superior mesenteric lymph nodes. Okay, right and left, both side, right and left para-aortic lymph nodes. Okay, inferior mesenteric lymph nodes, external iliac lymph nodes and internal iliac lymph nodes. Okay, so these are the lymph nodes of the posterior abdominal wall. Okay, so now coming to the veins. What are the type of veins? Okay, veins কি কি আছে? প্রথমে হচ্ছে inferior vena cava, then inferior mesenteric vein, vein গুলো একটু লিখে নে। rather than inferior vena cava আর কি কি পাবি? inferior mesenteric vein, superior mesenteric vein, and you could not forget that is the portal vein. Okay, so portal vein, how does it form and where it form? Behind the neck of pancreas by the union of superior mesenteric vein and the splenic vein. Okay, so these are the four veins. Posterior, behind the neck, posterior side of, yeah, behind the neck of pancreas, same posterior surface, both are same. Okay, now coming to the nerves, last one is the nerves. Okay, so what are the nerves you will get? First one is lumbar plexus. Tell me how the lumbar plexus is formed and which are the branches? Lumbar plexus এর branch গুলো বল কি কি? So study the lumbar plexus once again, please study the lumbar plexus. Okay, ilioinguinal, iliohypogastric আর genitofemoral, obturator আর femoral, তাই তো? So this is all about the lumbar plexus. So these are the additional nerve: iliohypogastric, ilioinguinal. Okay, lateral cutaneous nerve, genitofemoral nerve, femoral nerve, obturator nerve, and sympathetic trunk. Already I have discussed about the sympathetic trunk. ঠিক আছে, sympathetic ganglion টা পড়বি। Okay, so this is both side, left and right. So that is all about the posterior abdominal wall. Okay.